Thank you. Thank you for your invitation, Dr. Gupta and Dr. Nags. I really appreciate the opportunity to present virtually, and thank you for the introduction to the topic. I have some disclosures, either honorarium to myself or to my institution for participation in some of the trials that I will speak about. So the overview in terms of what to do after CDK4/6 really, I think, is highlighted in this summary slide. And that is, if we understand the genomic mechanisms of resistance, either to the CDK4/6 or to hormonal therapy or both, this should provide us some insights as to what might be the optimal next line of therapy. So I will briefly cover ESR1 mutations as predictive of resistance to AIs, but not to CDK4/6. And really that SERDs are better than fulvestrant. And then moving on quickly to that PIK3 mutations are associated again to resistance to hormonal therapy, and they are associated with the poor prognosis, but benefits still exist to a CDK4/6. And that lends the question of either sequential or combination with the CDK4/6. And then lastly, what can we do if there is a resistance to an actual CDK4/6 that we're aware of, such as alterations and cell cycle regulators? I don't have time with 20 minutes to cover all of the details of the various drugs, but I will try to provide some principles and examples to highlight these points. So what we know is after CDK4/6, so this is example from Paloma 3, some of the most common alterations at the right is percentage in ctDNA alterations at end of therapy. The most common one is an ESR1 mutation. And we know, and I'm sure you've covered some of this as the previous speaker, there are numerous agents that can affect estrogen degradation, and there's classes that behave similarly, but with slightly different mechanisms of action, whether they're PROTACs, SERDs, or pure SERDs. So one of the ones that I think is now commercially available in the United States is that of elacestrant. So this is the much discussed Elmereld phase 3 trial. And here all patients had previous endocrine therapy, of which one of them was given in combination with a CDK4/6 with up to one line of chemotherapy, comparing elacestrant to various different investigators' choice endocrine therapy. So what we do know is overall, the magnitude of benefit of this oral SERD elacestrant, I think, is modest at best in all comers. The absolute difference is 1 month in median PFS with a hazard ratio of 0.68. Where the benefit seems greater, at least in an absolute benefit, is that of the detectable with an ESR1 mutation. And here, the hazard ratio is more, I think, in line with what we'd like to see with 0.50 and a 2-month difference in absolute median PFS. I think more so, there's about 30% of patients remaining on therapy for more than 12 months. So clearly, if we can identify who those roughly 1 in 4 or so patients are, that would offer a significant clinical benefit. As another example, compared to fulvestrant as superior for oral SERD is the SERENA-2 study. Again, this is a randomized here phase 2 study. There was 4 arms, of which a 4th arm at a higher dose of camizestrant actually was discontinued due to toxicity, looked at 2 doses, 75, 150 versus fulvestrant. Patients could have had a prior CDK4/6, but it was not mandated in this study like in Emerald. And again, if you see on the left-hand side, those that had detectable ESR1 mutation at baseline had an improvement in PFS. Here is a little bit more striking with an absolute difference of 3 to 6 months, hazard ratio 0.33 versus to 0.55 for either dose of the camizestrant versus fulvestrant. But in the non-detectable ESR, you really don't see much of a difference, and I think highlights that fulvestrant can be an active endocrine agent, particularly when there's no ESR1 detected. So how can we sort of use this information in understanding how to leverage a greater duration on a CDK4/6? And I think we can learn this from the PADA-1 study. So the PADA-1 which was presented at ASCO in this year, was looking at patients in the first line setting, screening them over time for an ESR1 in ctDNA by PCR as the assay. If there was a detectable and rising ESR1 variant allele frequency, and on imaging there was no detectable progression, patients could then be randomized to staying on the AI and palbociclib or switching their endocrine agent, okay? So not changing the CDK4/6, but switching out the endocrine agent to fulvestrant. And what we see is in the sort of PFS1, as what we would expect, you do see a greater time on palbociclib at 12.8 versus staying on the AI despite having detectable ESR1 mutation, and at clinical progression was about 6 months later. So here's about a 6-month gain. Now, there was an optional crossover in which patients, when there was detectable by imaging progression, they could switch over to fulvestrant and maintain on the palbociclib. Here, the median PFS gain was only 3.5 months. So when you look at the combined PFS2, in which case you want to include your next line of therapy, here are the results a bit more impressive, where if you switch a molecular detection of ESR1, 29.4 months median PFS versus all comers in terms of staying on the AI and switching at time of clinical progression, not molecular, you're getting a median PFS of 14 months. And here the hazard ratio 0.37. So this concept is being further tested in the ongoing SERENA-6 trial. Exactly the same design, but the endocrine agent is not fulvestrant, is actually camizestrant when there is detectable ESR1 mutation as per a Guardant assay. Now, I believe earlier speakers have talked about how about using another, again, keeping on your CDK4/6. And here, for the most part, these patients were actually on palbo switch to ribo and switching out your endocrine backbone. And you've talked about the MAINTAIN study, so I won't go into this in detail. But again, switching to ribo versus getting a placebo upon progression on a CDK4/6, though it did not have to be the immediate line of therapy, offered about a 3 or a 2.5 month difference in median PFS, hazard ratio 0.57. Again, very modest overall. Here on this study, 42% had detectable ESR1 mutation on study entry. And when they looked at the co-alterations, those that were wild type had a very low frequency of what we would say are associated CDK4/6 inhibitor mechanisms of resistance, such as CCND1 amplification and FGFR1 amplification, versus the mutant ESR1 mutant group. They had a co-alteration, and about a quarter had CCND1 and about 10% FGFR. So when you grouped the results this way, where they were wild type, and in here, none of the cases had co-alterations of either CCND1 or FGFR, the hazard ratio is more impressive at 0.3 to have a second-line CDK4/6 having a prior CDK4/6 with about a 5.5-month difference in median PFS versus the mutant group. Here, they'll have very little benefit regardless. And again, here in this group, half the patients had a co-alteration. Now, we saw from San Antonio 2022, there was a similar design, but with palbociclib called the PACE study. The difference here is it's open label. There's a third arm which added a checkpoint inhibitor, avelumab, to the palbociclib and fulvestrant. And what's really, I think, interesting, first of all, by adding palbociclib, when again, most patients had previous palbociclib, but switching out your endocrine backbone did not really offer much benefit compared to fulvestrant alone. But intriguing, the addition of immunotherapy had a trend, a signal, but not statistically significant. And the hazard ratio, the median PFS is 8.4 months versus 4.8 months in fulvestrant. So why might that be? Well, in the pooled ctDNA analysis and again, think I saw on your agenda, this was earlier discussed, you see that tumor mutational burden is seen across sort of this quartiles on the Mona Lisa trials. And there is a small component that tends to have a higher tumor mutational burden. In that situation, you can see the curves seem to be less separated visually than those with a lower TMB. So could, in the high TMB, the addition of provision of a checkpoint inhibitor augment the effect of a CDK4/6, I think is interesting and potentially worthy of further investigation as a signal that we see from the PACE study. Really, I think we're going to have to wait for the post-Monarch study, which I thought we might see results at San Antonio this past a month ago, but we did not. So assumption is we will probably see data sometime this year in 2024. This is a randomized phase 3 trial in which patients could have had a prior CDK4/6 in either the metastatic or the adjuvant setting. And here they're randomized to abemaciclib plus fulvestrant versus placebo plus fulvestrant as a randomized phase 3 trial, and with PFS as the primary endpoint. Now, we can learn by looking at the post-progression samples to understand what are some mechanisms associated with resistance to CDK4/6. And RB1 loss or mutations, as we would expect, is one of the most sort of potent inhibitor mechanisms of resistance. It's not all that frequent and happens about 5% of the time. Another one that has come up that is significant from this study is PTEN loss or alterations. And why would PTEN loss lead to resistance to our current CDK4/6 inhibitors? And this is some nice preclinical work from Dan Jurik's lab from Mass General. And basically the mechanisms that PTEN loss leads to activation of AKT, which subsequently through P27 increases CDK2/6 activity. So remember, not only is there CDK4/6 with cyclin D, but CDK2 and cyclin E can be mechanisms of progression of the cell cycle from G1 to S. So here, this bypasses CDK4/6 through CDK2. And this is the concept, I think, which supports using inhibitors of PI3, particularly AKT, as they're downstream of PIK3 alterations with an AKT inhibitor. The previous speaker spoke to Capitello 291, so I won't go through this anymore in detail, except that, again, they utilized sequencing from the tumor, so archival tumor, which is paraffin embedded from either the metastatic or the primary. And they classified the unknowns into the non-altered category. And this is important as I show you where I think FDA basically had the label to being altered only, because about 44% was determined altered, 56% non-altered, and again, about 15% of that was unknown. So the previous speaker showed a fairly impressive in all comers improvement in progression-free survival from 3.6 to 7.2, hazard ratio 0.6. If you just focus on the known altered pathway, the hazard ratio improves to 0.5, and an absolute difference about 4 months in median PFS. If you look in the New England paper and just pulled out the unaltered out of the unknown and just showed the unknown, here, the hazard ratio is a little bit less impressive at 0.79, and the median difference in PFS is 1.5 months. So I think this speaks to why the unaltered pathway was not part of the label, at least by FDA. So I'm fortunate enough to be the PI of a CCTG trial called MA40 or Finer, which is essentially identical to the Capitello 291 study, but using Roche's compound as of an AKT inhibitor called apatasertib. Here, this drug is given for 21 days on, followed by 1 day off. The difference of this study is that it's a smaller study of 250 patients. It's run as an academic study through CCTG, and all patients are stratified with a liquid biopsy, a Foundation 1 liquid, and our unknown sort of categorization is essentially 0 on this study. So this study is close to being closed by this month, and hopefully we'll have data in an upcoming meeting either later this year or next year. Now, we do know that PIK3 inhibitors do have activity in this disease, ER positive, HER2 negative or low. but the Solo One study had very few patients with prior CDK4/6. In the Believe study, we had three parallel arms, non-randomized, where all patients had a prior CDK4/6 and then received, if they had a previous CDK4/6 with an AI, alpelisib plus fulvestrant. We saw in this single arm study of 121 patients that the median progression-free survival was 7.3 months. It's fairly respectable in the setting of prior CDK4/6. What I want to show you is what's called the volcano plot. So when we looked at the previous duration of duration on therapy of a CDK4/6 relative to the benefit of alpelisib post CDK4/6, we can see that regardless if you were on a CDK4/6 shorter versus longer, the benefit was somewhat similar, including those that were on the CDK4/6 for a very short period of time. At least based on the volcano plot, there's a visually higher, I wouldn't say statistically, percentage of patients alive without progression at 6 months, suggesting, as we know, in some of these patients where there's an alteration in PIK3, that may be the primary driver. And so why is this important? So at San Antonio this year, we saw the study called INAVO 120. So this study took what's called more endocrine resistance, either primary or secondary patients. So they had to either progress on or within 12 months of adjuvant endocrine therapy, and they had to have a PIK3 alteration that was centrally confirmed either on tissue or blood. With measurable disease, patients are randomized to the control arm of placebo, palbociclib, and fulvestrant. Again, no AI because progression was generally on an adjuvant AI on or within 12 months, versus Roche's alpha-specific PIK3 inhibitor, inavolisib, with palbociclib and fulvestrant. And here we see on the study about 80% had visceral disease. Primary endocrine resistance was about a third of the patients, and secondary about 2/3. And about the vast majority was enrolled by ctDNA, which kind of reflects the pattern of practice today. We saw a fairly impressive progression-free survival by this, what we call triplet therapy. And the control arm performed, modestly well, in fact, somewhat poorer at 7.3 months median PFS, but improved to 15 months with inavolisib plus palbo and fulvestrant, hazard ratio 0.43, and the median follow-up is 21 months. Overall survival has a numerical trend, but is not statistically significant by their criteria, not crossing the boundary at the interim analysis, but the hazard ratio is 0.64. We do see, I think, this toxicity profile to be a little bit different than alpelisib. You seem not to see as high of grade 3 to 4 rash. Hyperglycemia is also not as high, but you still get the GI toxicities such as diarrhea, nausea, and you get a higher rate of stomatitis. But generally, I think this study was fairly impressive as a late breaker in terms of the activity of the triplet. So I'm just going to end in the last few minutes of talking about what about using a more potent CDK4 inhibitor. We know CDK6 is more involved in the hematological sort of parameters, and that's why you get neutropenia. But what if you gave a more potent CDK4 inhibitor? And so there is one in development by Pfizer, PF 07220060. It's a pure CDK4/6 inhibitor, which has more potent activity than the current CDK4/6 inhibitors on the market. And again, here I want to show you part of CDK4/6 inhibitors is obviously with cyclin D, but as I showed you previously, CDK2 is involved with cyclin E and is also involved in pushing the cells from G1 to S phase. This is a phase 1 study, and there's various combinations of various endocrine agents, and it's a phase 1b study. And so what I want to show you is mainly the data in combination with the endocrine therapy, relatively small study still at 26. All of these patients, 100% of them, of the 26, all of them had a prior CDK4/6, and 3/4 had prior fulvestrant. You can see on the right table, the toxicity, you do not see as high rates of grade 3 to 4, neutropenia, as we see with palbociclib, ribociclib. The rate here is 15%. You do see a little bit more GI toxicity, diarrhea, and nausea, but generally you're not seeing the neutropenia consistent with being a pure 4 inhibitor. What was relatively impressive from this study is the activity in a very heavily pretreated population. Again, here the data set's 21 patients, but you're seeing an overall response rate of 28% and a clinical benefit rate of 52%. Again, all patients had prior CDK4/6 inhibitors. So I think this is impressive enough that studies are ongoing, phase 2 to phase 3 trials. So to conclude, I think if we understand the molecular mechanisms of resistance, remember the combination is a CDK4/6. Perhaps the resistance is not to the 4/6 inhibitor, but to the endocrine backbone. And that's where ESR1 detection, I think, is going to be clinically, have clinical utility. Do I think we should be giving a CDK4/6 after CDK4/6 today? I don't think so. I think Postmartic should be reporting out quite soon, and we need to wait for the phase 3 trial to establish it as a standard of care. Targeting PIK3CA and AKT really makes biological sense by the mechanism of resistance I showed you. And I think this is an area that we now have a new agent, capivasertib. This combination triplet of a PIK3 with a CDK4/6 shows very promising activity in the inavolisib study I showed you. But the question is, what if they put in a mandated sequence, and those that got placebo with their palbo and fulvestrant then received inavolisib second line thereafter? Obviously, you'd have to ask, what is the endocrine backbone there? Could you get a similar benefit sequence versus combination? The next generation potent CDK4 inhibitors are very promising, and we will all are interested in participating in those trials. I did not have time to say what other agents could we use. Well, clearly it's the antibody drug conjugates, trastuzumab deruxtecan based on DESTINY-Breast04, and sagetuzumab based on the TROPiCS-02 study have all shown survival benefits post CDK4/6 and will be part of our armamentarium. So thank you very much for having me present this, and I wish you all a great conference.